Hello, my name is Leo, and this video is on the point-of-care ultrasound approach to finding thrombus in the lower limb deep venous system. This video will have two parts. The first will discuss the technical aspects of the exam and some pitfalls. The second will be an introduction to clinical reasoning. I must warn you though, clinical reasoning around thrombosis can be challenging, and POCUS does not necessarily make it much easier. I'd like to thank Alberta Sono for their help with this project. Here we go. I do not have any significant disclosures, other than I think POCUS is a powerful adjunct to the clinical assessment. While listening to this video, and the next time you're picking up the ultrasound to scan a patient, I want you to really think about why you are scanning them and what your goal of the scan is. Next, you should be thinking about the practical process to accurately perform and interpret the examination so you do not become one of those operator-dependent statistics. Okay, let's look for some clots. I mean, how hard can it be? The vessels that we are interested in, which we will discuss shortly, are surprisingly proximal on the medial thigh. In fact, you will need to completely expose the inguinal ligament and ideally a bit above that with very careful draping for modesty. Also, as these vessels are relatively medial, slight flexion and external rotation of the hip is very helpful. In heavier patients, you may need a second set of hands to help move the abdominal outposts out of the inguinal crease for this exam. Finally, despite looking for deep veins, the locations that we're going to be searching are generally still quite superficial, and visualization with the high frequency or linear array transducer will be more than adequate. Now, what do veins look like? Differentiating artery and veins by ultrasound can be tricky. They're almost always paired, and arterial and venous blood are equally anechoic. The major features to differentiate arteries and veins on ultrasound are not that different than the ones that you memorize to differentiate the JVP and carotid when you're a medical student on internal medicine. Pulsatility and compressibility are key. Veins are most easily compressible, and arteries have a regular pulsatility and are quite resistant to compression. More subtle findings include wall thickness, where arteries will be thicker than veins, shape, as arteries are generally perfectly circular or close to it, while veins can take any number of shapes, and if you're experienced with color Doppler, direction of flow. While pulsatility and compressibility are quite reliable at differentiating arteries and veins, I urge you to look at multiple factors when making high-stakes decisions such as inserting central lines or diagnosing a DVT. Great, we've draped our patient, we've got our probe, we can identify a vein, now let's find some clots. Which of these vessels has a thrombus? What does a thrombus look like? It may surprise you to hear that an acute thrombus is completely hypoechoic, meaning that it looks identical to the surrounding blood on 2D mode. As a clot ages, it may develop some internal reflections allowing it to be visualized. This clip shows a maturing thrombus. It's not an acute thrombus. Those, remember, are perfectly black. Not only will looking for visible thrombus lead you to miss an acute clot, but you're more likely to be fooled by artifacts. There are many tricks that the ultrasound may play on you. Mirror image artifact, side lobe artifact, overgaining. Any of these may project what appears to be thrombus into a vessel lumen. Also, sluggish flow may result in spontaneous echo contrast, which can be seen on the right. This is not a clot. The key point? Don't attempt to visualize clots directly. The thrombi that you care about are as black as blood. So how do we detect an acute thrombus? Compression! Simply push the transducer into the soft tissue of the limb and watch the vessel collapse. Or not, if there's an obstruction such as a thrombus. How hard should you push? Well, a good rule of thumb is hard enough to compress the neighboring artery. This can be very helpful when you are trying to compress a significant amount of adipose tissue or have positioned yourself at an awkward angle. The left image is of a patient's right inguinal vascular bundle. The lateral vessel is pulsatile and quite resistant to collapse with compression. It is a high-pressure vessel, so an artery. The medial vessel starts collapsing with much less pressure, but does not compress completely. It contains an acute hypoechoic thrombus. This would be a positive exam for DVT. The image on the right is showing a vascular bundle from our patient's left inguinal fold. Both vessels compress completely. There is no thrombus in the left common femoral vein at that location. This is an essential point. When the segment of vein compresses under your probe, there's not a thrombus at that location, but there easily could be a few centimeters proximally or distally. As you can imagine, the more vein segments you compress, the more likely you are to identify a clot if there's one to be found. So what vein should be compressed? Let's start with a simplified vascular anatomy that focuses on the deep system and arterial landmarks. At the bottom, behind the knee, we have the popliteal trifurcation and the ascending popliteal vein. In the distal medial thigh, the femoral vein emerges from the adductor canal and runs its way up the thigh until joining the deep femoral vein, and then becomes the common femoral vein at that point. The femoral vein is sometimes referred to as the superficial femoral vein, as it joins the deep to become the common. However, this can be misleading because the superficial femoral vein is part of the deep system. Therefore, the term femoral vein is favored. In quick succession, the lateral perforator vein and the greater saphenous vein join the common femoral vein before it crosses the inguinal ligament and gets renamed as the iliac vein. So where do we look for clots? You may have heard about a 2-point or 3-point protocol and the various excellent sensitivities and specificities that have been reported for them. These abbreviated protocols are an attempt to balance the relative frequency of thrombi occurring at each segment of the deep venous system and the time of examination. However, clots have been documented to occur with reasonable frequency at all points of the deep venous system, and I would argue that by the time you've found the machine, prepped your patient, got your landmarks, it takes minimally more time to compress the entire visible deep venous system compared to just part of it. Venous thromboembolism is a high-stakes diagnosis, and POCUS users are already disadvantaged by not having the same volume experience or application of advanced techniques that radiology techs and radiology departments have. So why add sensitivity limitations from the protocol as well? Anyway, that's just my thought. But I would advocate for the internal medicine ICU context, compress the entire accessible deep venous system with special attention to the points of venous confluence. Now, the most common error is not visualizing proximal enough up the inner thigh. In order to explore all the key areas, knowing your venous landmarks is very important, and these landmarks are not as difficult as they seem. Despite the apparent complexity, I simply remember the venous takeoffs as medial, lateral, and deep. They will almost always be in that orientation. When I start, I orient myself by finding the superior medial approach of the greater saphenous vein. Then I follow the common femoral vein as proximal as possible into the inguinal fold. Then I start compressing at this point, the point that's most proximal, and work distally by compressing every 1 to 2 centimeters. You must be very careful to ensure complete closure of each point, especially at each of the venous junctions. I then follow the femoral vein as far distally as possible down the medial thigh. Eventually, the femoral vein will dive deep into the quadriceps muscle and enter the adductor canal, where it will be lost. However, it will reemerge in the popliteal fossa as the popliteal vein. From here, the popliteal vein must be followed until the trifurcation. Okay, let's look at some images. Starting in the right inguinal fold, what do we see? Well, there's a very compressible vessel on the right that would be in keeping with a vein. There's also a junction that leaves medially, and in this case a bit more superiorly, suggesting that it's the common femoral and greater saphenous vein junction. As we move the probe more proximal, we find the common femoral vein, and somewhere in here it will transition to the external iliac vein. Remember, they only differ based on the landmark of the inguinal ligament. Skipping a few steps, we would compress all the way down the common femoral vein until we get to this junction, and very carefully ensure the complete collapsibility. I've skipped ahead a few images, but here we're at the common femoral vein, and you can see a compressible lateral vein coming off of the left side. This would be the perforator vein, as it is oriented laterally. Another key landmark at this point is that the arterial system has divided into both a superficial and deep femoral artery. This is a good clue that this junction is near. Incidentally, it looks like there's a visible valve in the lateral perforator vein. Skipping ahead to the junction of the femoral vein and the deep femoral vein. And now that we are past all of our major junctions, we compress every 1 to 2 centimeters down the entire length of the medial thigh. It will eventually dive deep into the quadriceps muscle, And the rate of descent and the degree of adipose will influence how far you can actually follow this before it is lost. Now remember, you aren't finished yet. Don't forget the popliteal. This vein can be tricky to find in some patients. It's very superficial and easily collapses with just a little bit of pressure. The key is to be very, very gentle. Once it's been found, trace and compress it as proximally as possible, and then as distally as the trifurcation. The trifurcation is technically the end of the deep system, and the management of clots found below the trifurcation is different than that of the deep venous system and will not be discussed today. Okay, self-quiz time. I'm going to show you a non-compressed clip sliding down the right leg vessels, and you try to identify them. Remember, medial, lateral, deep. It is important to remember this anatomy, as medial and lateral will be opposite on the left and right legs. Simply remembering right and left takeoffs will confuse you if you're going to be scanning both legs. Okay, now for the left side. Feel free to stop and play this one again if you need to. It's a bit tricky because the lateral perforator and deep femoral vein junctions are very close together. Okay, let's put all this together. Step 1. What are the odds my patient has a DVT? We'll talk more about this in part 2, but we need to have a decent pretest probability if we're even going to bother picking up the probe. Next is step 2, patient draping and leg positioning. Remember, you need to expose above the inguinal fold and get an extra set of hands if you need it. And of course, be sure that modesty is maintained. Pick your linear probe, unless of course you need the curvilinear for adipose penetration. But in the vast majority of cases, the linear probe will be sufficient. Step 4, identify your landmarks and start compressing. Finally, is there a clot or not? And most importantly, what are you going to do next? The interpretation of this exam can be really tricky. If you did the exam, you must be suspicious that there is an underlying clot. But what if you didn't find one? Could there still be one there? Compression ultrasound for DVT is a technically challenging exam, and I would be very wary of overconfidence in your performance. As with most POCUS applications, I am extremely wary of ruling out a diagnosis based on my POCUS findings alone. You need many other data points and clinical judgment. The likelihood ratios are not the same as for diagnostic imaging. I should also mention that compression ultrasound can only evaluate compressible vessels, which does not include the iliac veins or the IVC. These sites are important considerations in postoperative and pregnant patients. They can be evaluated with advanced spectral Doppler and augmentation techniques that could be part of a special training program, but would be included with a comprehensive diagnostic study. An area of non-compressibility isn't a slam dunk either. Are you sure the vessel wasn't collapsible? Did you apply enough pressure? That rule of thumb is that if the artery is compressed, there should have been enough pressure to collapse the vein. Of course, there are other pathologies or benign findings that could prevent a vessel from collapsing. These need to be kept in mind too. So, you think your patient has a DVT, you did your exam, it was either positive or negative. Well, what are you going to do next? Of course, POCUS only works in the context of all these other factors, but how do you necessarily interpret your findings? Here we go. I guess we're going to have to listen to part 2.